Okay, good morning, everybody. Thank you, Dr. Zaytouni, and thanks, everybody, for inviting me. And I'll try to talk in the coming 45, 50 minutes about spirometry, which is something that's very close to my heart. Is it working? It is? Anyway, we'll get started. So, I will start with this case, if you don't mind. So, a 52-year-old female patient, heavy smoker, with history of chronic dyspnea, has this PFT. Okay, just have a look at it. So you have FVC, FEV1, FVC ratio, and then some other findings. This is the volume time curve and flow volume loops. And this is the technician comments data acceptable and reproducible for puffs of salbutamol inhaler given. So my question to you, what is the diagnosis? Is it bronchial asthma, emphysema, pulmonary fibrosis, or upper airway obstruction? So who thinks it is bronchial asthma? I know it's quite a bit of disadvantage for those in here. So what do you think? Is it bronchial asthma? Is it emphysema? So who thinks it is bronchial asthma? Nobody. Emphysema? Nobody. Pulmonary fibrosis? Upper airway obstruction? Okay, so we have one vote there. So I'll keep the answer to the end. And I showed you this example just to show you how hopefully by the end of my presentation you'll be able to find out what is going on in this particular patient. So spirometry, what is spirometry? In fact, spirometry is the most essential part of any pulmonary function test, as probably Dr. Zaytouni has alluded to earlier. And it is done with a machine called the Spirometer that intended to do a certain set of lung volumes called the dynamic lung volumes. But let's talk about spirometer first. So this is the first spirometer that was used in the clinical practice. How many years do you think this spirometer was used? It was more than, yeah, probably. No, even more before that. More than 110 years ago. In fact, in the early years of the 19th century. And then in the 50s, this was the spirometer that was used. As you see, there are two cylinders. This is where the hose is hooked and the patient will breathe in and out. Should we wait or? Why don't you move to that side? So do you mind moving to this side? We have plenty of room. Should we wait? Okay. Anyway, so what you see is that you see two cylinders within each other, and there's like a roller here and another one there. And the breathing takes place through this thing here. This rotates, and there is a pin where the recording of the breathing takes place. And to my surprise, this has been used for humans and also for animals. And I didn't know really that cows had, PFTs. You see, these are the two cylinders, and this is how the recording takes place. Probably. This is a more sophisticated version of that particular machine. But then in the 80s, this is the thing that was used, and in fact, during my medical school years, probably Dr. Dwayne knows about that. We used to use this machine in our physiology lab to record our PFT. We are not that old. That was in the 90s. And then in the 90s, it became a little bit more computerized. Okay. Look at this. This is the modern spirometer. And although it looks giant, it is very, very sophisticated. And there are smaller versions of it, but probably the best of which is the portable spirometer that is as good, probably, as the large and sophisticated one. And even nowadays, there are like small hardware that you connect to any computer with the software built in, and you can do a PFT right in your office, or even put it in your pocket. This is a pocket-size spirometer, and it has also other features like pulse oximetry and these things. So things got really, really better with time. And if you remember when I spoke earlier, I mentioned that spirometry is the most important part of any PFT, and it measures something called dynamic lung volumes, and they are basically FVC and FEV1, forced vital capacity and forced expiratory flow in the first second. These are the most important and critical dynamic lung volumes, and they are different from the static lung volumes that we see in any lung volume study. You see, these are the lung volumes: inspired reserve volume, tidal volume, expiratory reserve volume, and residual volume. And these are capacities. Capacities mean, a combination of two or more volumes: inspiratory capacity, FRC, TLC, and the vital capacity. Now, I brought this video just to show how. I would suggest, guys, that you move this side. Otherwise, you'll lose the opportunity. We have plenty of seats here. Okay. So how do we perform spirometry? I'll show you how this is done. It's simple. When you see it, you will understand it more. So there is the patient, nasal clip is placed so that no air will escape through the nostrils. And you see how tiny the spirometer is. There is a mouthpiece, and then the subject or the patient takes a maximal inspiration and then puts her mouth really well tight and sealing around the mouthpiece, and then she exhales as fast and hard as she can and continues exhaling until no more air can come out. Sometimes we ask the patients to stop because they've probably exhaled for long enough. We don't want to have them hurt. And then the report is printed. We do 3 sets of spirometries, and then we do certain criteria to assess whether these are valid or not. And as you see, the report comes with a set of numbers and 2 graphs. Okay. So the numbers that we have are basically the FVC, FEV1, and the ratio. Then the peak expiratory flow, forced expiratory time, and the maximal mid-expiratory flows that we will not really talk about much here because they are not very, very specific. Then the curves we have, or what we call the spirometric curves, are those, the volume time curve and the flow volume curve or loop. So let's start with the volume time curve. So we have the volume in the y-axis and the time in the x-axis, time in seconds, and the volume in liters. And as you see, this one is numbered from 1 to 6. And this is how a normal volume time curve looks like. It has a steep rise, then some sort of convexity outside, and then there is some sort of plateau until we reach the end of the study. Now, the end of the study is marked here as the forced expiratory time. And this is important because we need it to be higher than a certain number. 6 seconds is considered acceptable, but 10 seconds is optimal. And then against that, in the volume axis, you have the FVC, which is the maximum amount of air that you could have exhaled after maximal inspiration, but it has to be forceful. Now, against the 1 second in the volume axis, you have what? The FEV1. So what is the relation between the FEV1 and the FVC? You could see that it is almost around 80% of the FVC. You see, this is the FEV1 from here to here, and FVC from here to here. If you see something like that, then most likely you are dealing with a normal individual. Now, what about the flow volume curve? As you see, flow is plotted here in the y-axis in liters per second, while the volume is plotted in the x-axis in liters, and there is no time axis here. So the only way that you can tell what is the time is when the machine gives you in the curve what the time is. So this is the flow volume curve. As you see, there's steep rise until you reach the top, and then a little bit of a slope down until you reach the bottom. So the patient takes a deeper breath before putting the mouth into the mouthpiece until he reaches his total lung capacity, or TLC. This device or this test is not meant to measure TLC. You cannot measure it. But this marks the TLC. Then the patient or the subject exhales all the air in his lung forcefully until we have the mark of the RV, or residual volume. Okay, so from TLC to residual volumes, our vital capacity, but you are doing it forcefully. That's why it's called forced vital capacity. So the width of the curve is the vital capacity. Believe me, if you focus a little bit and concentrate on the flow volume curve, you will learn spirometry very, very well. Now, most machines will put a 1 second mark on the curve itself. And this 1 second mark, if you plot it in the volume axis, you will get the FEV1. And as you see here, the FEV1 is almost 80%, or a little bit less, a little bit higher than the, FVC. And this represents a normal, proportion between FEV1 and FVC. What about the height of the flow volume curve? What do you think it represents? It in fact represents the peak expiratory flow. Okay, this is the maximum flow that we can exhale. And as you see, it comes very early, even before the 1 second mark. And it is similar to what we do at the bedside, which is the peak flow meter. If you see this one in your clinic or something like that, the only difference is that we use here liters per minute, but here liters per second. And this decreases with obstructive airway disease. All right. Now, the peak expiratory flow is effort dependent. So if the patient is not producing good effort, this is likely to be lower. While the slope of the curve represents the effort independent portion of the curve. And we mean by this the maximal mid-expiratory flows. This is not very important at this point of time because it's quite non-specific. So we'll leave it for now. Now, I'll just go over this one, which is similar to what we saw earlier, but it has more information and will give you more data as well. As you see, there is a small circle here, or loop. This is the tidal volume loop. So we ask the patient initially to take, a gentle breath in and out, okay? And then take maximal inspiration to TLC, okay? Then the patient exhales forcefully and maximally until he empties his lung to mark the RV. And then we ask the patient again to take another inspiration to fill up his lung, reaching TLC again, and this is going to be the inspiratory vital capacity, which is similar to the forced vital capacity, basically, in normal individuals. Okay, so you see how much data we got from this particular study. This is called the flow volume loop, inside of which is the tidal volume loop. And you can have more data as well. So from the end of the tidal volume loop to the right, to the residual volume, we have the ERV, or expiratory reserve volume. And from here to here, we have the inspiratory capacity, which is different than the vital capacity. The vital capacity is from here to here. And this one here is the tidal volume. In fact, if you look at this curve, it looks very much similar to the static lung volumes. The only difference is that you have to put this a little bit rotated. And the things that you can't really get from the flow volume curve or loop are the things that have the residual volume in it. So again, spirometry cannot get you the residual volume, so you cannot get the FRC or TLC. But the rest of the volumes, you can extrapolate them easily from the flow volume loop. Now, in order for us to get a study and evaluate it and make sure that this, in reality, represents the patient's study, the ATS produced some guidelines for acceptability and reproducibility. So let's talk about acceptability. There are three important things. First of all, there should be good start of the study, okay? And there should be smooth flow volume curve, particularly in the first second. And then there should be a good end of your study. So how that works? So let's start with the, this curve. This is a typical acceptable curve. It has good start. I'll talk about that. Smooth curve up to the 1 second. And then good end, and there is no air leak. So let's start with the good start of the test. As you see, if you want to make sure that your flow volume curve fulfills this criterion, look at the peak expiratory flow. It has to be sharp and rounded. Okay, if it's not sharp and rounded, then you have to question. Then you have to question it. The other thing is that if you see something like this, so what do you think? Is it sharp and rounded? No. So it could either represent a disease state or it could represent something related to the patient's effort, okay? And the technician usually would report that, okay? So most likely this patient had poor initial effort. Now, smooth flow volume curve, outline in the first second mainly, like cough in the first second, variable effort, glottis closure, early termination of effort, or obstructed mouthpiece and air leak are those that may affect your quality of the study during the test itself. So let's take examples. So for example, here you see the volume time curve. There's some sort of distortion of that curve at this point here before the first second mark, but it's not really clear. But if you look at the flow volume curve, it becomes very, very clear. This is nothing but a cough. If a patient coughs before the 1 second mark, this will markedly affect the FEV1. So the study should be discarded. As you see, the patient coughed after the 1 second mark, but that is okay. Here you see that the curve is not really clear, and you see the other curve here is much more obvious that there is an issue with it. This is nothing but variable effort, and you see that the study was terminated at 3 seconds, so there is early termination. So there are two things that makes you reject this study. Now, some people are capable of closing their glottis when they breathe forcefully, or they may put their tongue into the mouthpiece, and this may result in something like this. You see that there is some sort of a horizontal line. There is no change in volume while time is changing, so this indicates obstruction of some sort, and it is shown here by abrupt termination of the flow volume curve at the end, as you see here. Air leak is hard to tell unless the machine will tell you, or you see something like this. So during inspiration, exhalation, you are okay, but when the inspiratory part is done, you see that there is more air, in fact, than during exhalation. So this indicates that probably there is leak, or probably the patient didn't take maximal inhalation to TLC during the study. So if it is significant, then this will be rejected. The last thing that we have to take in the acceptability ATS guidelines criteria are good end of the test. So there should be plateau of flow volume curve of around 1 second, and there should be reasonable duration of effort. So, for example, this patient has a big plateau. As you see, the patient breathed for 10 seconds, not only 10 seconds. In fact, it continued here. Another 10 seconds, so there are like 20 seconds of exhalation, and this is probably an indication of mild airway obstruction. But you don't need this much of plateau. In fact, what you need is around 1 second of plateau 6 seconds of a test is considered acceptable. 10 seconds is considered, optimal. What happened if there is bad end of the curve, the flow volume curve, is that you will see that there is a downward concavity at the end of the curve, as you see here, while it should be an upward concavity. Is this working, or is it working? Okay, good. So upward concavity indicates that the test is done appropriately. So in summary, for your flow volume curve or your spirometry to be acceptable, it has to have a good start, that is sharp rounded peak expiratory flow, no artifacts in the first second, and there could be a good end. Don't forget the air leak that I've spoken about earlier. Now, for reproducibility, we have to have two things. In fact, we do 3 studies, and we take the 2 studies with the largest numbers, and we compare FVCs in these 2 studies. They should be within 150 milliliters, and similarly the FEV1. Now, sometimes we do report non-reproducible studies, and this is because it will still give us information, although it didn't fulfill the criteria. So let's look at these studies. We have 3 studies here, 1, 2, 3. Do you think they are acceptable? They look acceptable, right? Based on the criteria I've mentioned. And they are very close to each other. And if you look at the numbers, they are within 150 mils from each other. So they are all considered acceptable and reproducible. While here, what do you think? We have 3 morphologically acceptable studies, but they are far away from each other. So they are not reproducible. In case you couldn't get reproducible studies, then you report the study with the largest FEV1 and FVC combined. So leaving physiology, let's talk about disease state. We have 2 disorders in spirometry. We have obstructive disorders and restrictive disorders. So starting with an obstructive disease, asthma or COPD. So first of all, this is the volume time curve. We have up to 25 seconds in this particular curve. This is the predicted curve, and this is how the curve should look like in reality. So a steep rise, concavity inside, then some sort of plateauing, okay, because the patient has exhaled most of his vital capacity in the first second. Now, this is a patient with a disease, right? What sort of disease? Most likely what? Obstruction. Why we say that? Because the curve is some sort of flattened. The steep uprise is gone, and it's becoming similar to a straight line. It's not a straight line, but it's close to that. So this indicates obstructive airway disease. Why is that? If you plot the FVC, which is at the end here, you see it is over there, and this is less than the predicted, as you see. The predicted FVC will be here. What about the FEV1? It is much less than the FVC, which means that the FEV1, FVC ratio will be what? Very low. Okay, so this indicates what? Obstruction. In these patients, we usually give bronchodilators, 4 puffs of salbutamol, and we repeat the study after some time. And this is what we get in this particular patient. You see, the morphology of the curve has improved towards the normal. It didn't reach normal yet. The FVC has gone up, as well as the FEV1 and probably the ratio. So this is basically how we know whether the patient has obstructive disease or not based on the volume time curve. And in order to make sure that there's significant bronchodilatory effect, we have to have 12% plus 200 ml increase in either FVC or FEV1 after bronchodilators. Now let's go to obstructive pattern in volume time curve, okay? Sorry, flow volume curve. So this is the flow volume curve, as you see, and this is the predicted curve. So let's look at the features of airway obstruction here. Number 1, what happened to the peak expiratory flow? It is now lower, right? Which is something expected with obstructive disease. That's why we use the peak flow meter at the bedside. What happened to the usual descent or morphology of the descent of the flow volume curve? See, it has become scalloped or scooped out, very concave outside. And this is very typical for obstructive disease. When you see this, there must be obstructive component to the patient, okay? So this is the second feature. Third feature is the 1 second mark. Where is it located? Near the TLC or near the RV? It is closer to TLC, right? Which means the FEV1, FVC ratio is much lower than the normal, which is 70%, okay? Then as you go to the FVC, you see that the FVC is lower than the usual, okay? And here it is really important to understand what happened. In fact, here there is more, the residual volume here is more than what you've expected to a normal individual with same, body size. This indicates that there's some sort of air trapping, okay, which will happen in many cases of airway obstruction, small airway obstruction. And in fact, the FVC has moved this way and there is air trapping because the RV has increased. And so this is the fourth feature. And if you look at the inspiratory component over here, it is what? It's completely normal because inspiration does not really change with, with obstructive disease. When you give a bronchodilator, what happened is that your peak expiratory flow, your morphology of the curve, FEV1 and FVC have improved to some extent, and this also supports an obstructive disease. Now, this is a specific form of or characteristic pattern of emphysema, which is the dog-leg appearance, where you have sudden drop in flow after the peak expiratory flow. And the reason for this is that emphysematous patients have very fragile small airways. So with forceful exhalation after reaching the peak expiratory flow, their small airways collapse, and that's why the flow drops significantly with an angle. They call it dog-leg appearance. And this is very common in emphysema. And just to convince you, I'll bring a dog. Which leg you will choose? This one? So we'll put this one here, dog leg, right? So I don't know why these people bring legs and dogs and medicine and cows. So features of obstructive disease. The diagnostic feature is drop in the ratio, less than 70%. Other features, low FEV1, low FVC, can be normal also. The maximal mid-expiratory flows are low, but this is non-specific. Peak expiratory flow is, decreased. Now, forced expiratory time could be decreased, but could be increased in some cases. There's significant bronchodilator response, which could be there or not there, and concave or scooped out descending portion of flow volume curve. So let's go to the restrictive disease. So this is the normal volume time curve, as I've shown you earlier. And this is the volume time curve of a patient with restrictive disease. What is the difference in morphology? It doesn't look much different. It looks exactly the same. But the only difference is that it is smaller. So morphology is the same, but the curve itself is smaller. What about in flow volume curve? As you see, the peak expiratory flow here is what? Normal. And this happens in patients with high elastic recoil, like patients with interstitial fibrosis. We call this parenchymal restriction. And what happened to the descending limb of the curve? There's steep slope here, which means that the patient emptied his lung very, very fast. And this is very typical for patients with parenchymal restriction. And as you see, the 1 second mark is very close to the RV here, which is residual volume. So the FEV1 and FVC ratio is either normal or high, and the inspiratory portion of the curve is normal. So as you see, the RV has moved towards the TLC, but there's no air trapping here because the whole total lung capacity has shrunken. Now this looks very much like what? I hope. So they call it witch's hat. So witch's hat appearance in flow volume curve is very characteristic for patients with parenchymal restriction, like interstitial lung disease, like IPF or sarcoid, etc. Now, this is another form of restrictive lung disease. As you see, the morphology of the curve looks the same, normal, right? But the only difference is that if you compare it to the predicted, it is much smaller. So we could see this in patients with musculoskeletal restriction, like patients with kyphoscoliosis. It is another restrictive lung disease. Now, can we see it in normal individuals? The answer is yes, if they have small lungs. Like if you go to, Southeast Asia, the body build there is much smaller than Caucasians, and probably smaller than ours, and that's why they may have smaller lungs and they may have similar finding. That's why you have to compare it to the predicted to that particular race. Okay, so we see this particular kind of restriction, as I've mentioned, in musculoskeletal restriction. What about this one? I've shown this earlier, and I've told you it is indicative of poor effort. The curve is small but concave upwards. So small and concave could indicate poor effort, but it also possibly indicating a disease. Patients with neuromuscular disease who cannot have an effort. That's why it is the same as poor effort. Okay, so if it is reproducible and the technician, notes are suggestive of that, then you have to consider neuromuscular disease. Usually in the history you will find that. So we've seen 3 forms of restrictive patterns, and when you look at the numbers, the most important feature is the decreased forced vital capacity. Now the ratio could be normal or even high, okay? If EV1, as we've mentioned, will be preserved or could be a little bit decreased, the maximal mid-expiratory flows will be low, but this is non-specific. Peak expiratory flow could be normal, could be increased, could be decreased, depending on the type of restriction you have. And in parenchymal restriction, there will be steep descending limb of flow volume curve. Okay? Now, I noticed that Dr. Zaitouni have shown different grading of severities. And based on the guidelines that I've used when we published the book, if EV1 is used to grade severity of any spirometric issue, so even restriction or obstruction, so mild if it is more than 70, moderate 60 to 70, moderately severe 50 to 60, severe 35 to 50, and very severe less than 35. If this has changed, probably I'm not aware of this at this stage. I think the ATS guidelines are coming this year, right? The new ATS guidelines. Now, these are examples of obstructive diseases, bronchial asthma and COPD, and restrictive diseases, and I've spoken about that, so I'll just skip it for the sake of time. So let's go to upper airway obstruction. Spirometry is probably the only way you can diagnose upper airway obstruction because of very characteristic morphologic flow volume loop. So if you have variable upper airway obstruction that is extrathoracic in location, that is above the sternal notch. Example of that is dynamic tumor of the hypopharynx or the upper trachea. We mean by dynamic is that it moves with breathing. Vocal cord paralysis, dynamic subglottic stenosis, and if there is external compression of the trachea by goiter, for example. So what happens here is that exhalation will be fine because this is outside the chest. The problem is that when the patient takes a breath, the positive, the negative pressure within the trachea will suck the tracheal wall and the tumor or whatever in, and that's why you will hear stridor during inspiration, right? Okay, and that's why the inspiratory limb of the flow volume loop will be flattened, okay? What about the dynamic intrathoracic upper airway obstruction? Examples of these are dynamic tumor of the lower trachea, tracheomalacia, dynamic tracheal stricture, etc. or even if there is retrosternal goiter. Even sometimes Wigner's can give that. So the obstruction is over here, and the obstruction happens during inspiration or expiration. Like bronchial asthma, it will happen during expiration because the positive intrathoracic pressure will compress the intrathoracic component of the upper airways and cause more narrowing. And that's why the affected portion of the flow volume loop will be the expiratory limb of it, and you will see it in this particular fashion, flattened. Now, if there is fixed obstruction, whether extrathoracic or intrathoracic, like if there is non-dynamic tumor at any level in the upper airways or fibrotic stricture that happens commonly, or not very commonly, after decannulation of trach, like 6 months or so later, what will happen is that you will have fixed obstruction both during inspiration and expiration, and you will have like a rectangular kind of flow volume loop. And for you to remember which one is which, I suggested this kind of diagram. Just put the patient upside down with the horizontal line against the patient's sternal notch, which marks intrathoracic or divides the intrathoracic from the extrathoracic component of the upper airways. So if the flattening is down, then it indicates that it is in the extrathoracic portion. If the flattening is up, then it is in the intrathoracic portion. So almost done. So I'll just skip this for the time's sake. So does this look to you normal? This is the predicted, and this is FEV1, FVC. Does it look normal? It looks normal, right? What about this one? Speak up. Obstructive. Okay, clear, right? This one is emphysema. Obstructive again, but because of the dogleg pattern, it is suggesting emphysema. What about this one? Parenchymal restriction, because we have the witch's hat, or the ice cream cone for Dr. Zaytouni, who's hungry probably. And this one is what? Small with good morphology. It indicates musculoskeletal restriction. And if you have it small and convex, then this is most likely neuromuscular restriction. So this is summary of the flow volume loops in airway disease, but in upper airway, remember that if there's flattening of the expiratory component, it is what? Intrathoracic variable obstruction. If it is in the inspiratory component, it is extrathoracic upper airway variable obstruction. If you have it like rectangular in shape, then this is what? Fixed obstruction in the upper airways, whether intrathoracic or extrathoracic. So approach to spirometry, and then we'll go to solve some examples. So first of all, review the clinical history when you get the report. Then patient's demographics. Just make sure that whether the patient is Saudi or Egyptian or Caucasian or like Filipino, etc. And very important to read the technician's comments. Very, very important. Then examine the volume time curve. Okay? And here you have to look at the technical quality of the curve, the size and shape. Both obstructive and restrictive disease will make the size of the volume time curve smaller, but the morphology will be different. Components of the curve, as I've mentioned, and then the post-bronchodilator curve if applicable. Then examine the flow volume curve or loop, technical quality again, size and shape, components, the post-bronchodilator study, and then the spirometric data. Examine FEV1 and VC and the ratio, very important. Examine the post-bronchodilator values of these two and their ratio as well. And then examine the maximal mid-expiratory flows that I'll not spend much time talking about here, and the rest of the spirometry, and then consider special situations that I've spoken about earlier. So let's go to the first case that I've shown earlier. 52-year-old female, heavy smoker, history of chronic dyspnea. Now these are her spirometric data, numeric data. And these are the curves, and this is the technician's report, data acceptable, reproducible, 4 puffs of salbutamol inhaler given. And so I'll just walk you through, okay, and then I'll ask you questions. These are the choices. So let's start with the volume time curve. So what do you think about it? Is it the volume time curve that you would have expected for normal individuals? Or it is flattened? It is flattened. Not only that, there is like prolonged exhalation around 17 or 18 seconds, which also could happen with what? Obstructive disease. What about the red line? What does it indicate? Post-bronchodilator, and there is improvement in the morphology of the curve. So at least we have an idea that this could be what? Obstructive disease. What about the flow volume loop? So number one, the peak expiratory flow looks, I don't have predicted here, but looks low and scalloped, descending limb of the loop. But what do you see here? Yeah, the dog leg is here, okay? So, and the other thing is that you see that the FVC is low and the FEV1 is much lower than the FVC, indicating that the ratio is very, very reduced, and the post-bronchodilator study is improving. So we are dealing most likely with emphysema, but let's look at the numbers. So FVC is 46% of the predicted, so it is low. FEV1 is 15% of the predicted, which is very, very low. It's less than 35%. So if this patient has obstructive disease, then this is a very severe obstruction. After and the ratio, as you see, it is only 0.27, 27%, which is very, very low. Okay, so this diagnosis what? Obstruction, right? Severe, very severe obstruction. Is there significant change after bronchodilators? So for the FVC, there is increase by, this is 1.5 liters. It went up to 2.3 liters, so this is more than 200 mils, and more than 12%. So this is significant, response to bronchodilators. Similarly, probably in the FEV1, the FEV1 didn't change much, probably 100 something, although the percentage is significant. But we need one of them, FVC or FEV1. So what is your diagnosis here? So the answer is emphysema. So at least we improved, right? So from the beginning it was really hard, but now it is easy. So let's go to another example. I have probably 5 more minutes, right? 74-year-old female patient, Caucasian. This is her. Let's forget about the numbers. I like the graphs. So what do you think about, now, first of all, the technician's comments, data acceptable and reproducible. So what do you think about the volume time curve? Looks normal, right? Excellent. What about the flow volume loop? Let's look at the expiratory component. This is the predicted. The predicted ends here. So the patient did even better than the predicted. And the inspiratory component is there. So what is this inside? Tidal volume loop. Excellent. So do you think this patient has any abnormality? What? Excellent. So you see that there is some sort of this one here or here? Yeah. So yeah, I'll talk about that in a minute. So FVC is 99% of predicted, which is normal. FEV1 is 108% of the predicted, which is what? Normal. FEV1, FVC ratio is 81%, which is normal. Even the FEF 25 to 75 is normal. So all the numbers are normal. So what is the problem with the morphology of the curve? Okay, so I brought this up just to not to confuse you with the intrapulmonary, upper airway obstruction. Whenever you have flattening of the curve, that is normal, basically normal. I mean, the peak expiratory flow is normal and the curve is normal. The numbers are normal, then this excludes upper airway obstruction, okay? And this is considered a knee, and it is in fact a normal variant, okay? So don't confuse this with variable intrathoracic upper airway obstruction. Okay, quickly, so what do you think about the flow volume, the volume time curve? It looks normal, right? What about this one, the flow volume? This is the predicted. So the peak expiratory flow is normal. There is steep descending portion of the curve. The 1 second mark is very close to the RV, so we are okay. The FVC is much lower than the predicted. So it looks very much like witch's hat. So this is very characteristic for parenchymal restriction. And if you look at the numbers, FVC, which is the most important part for this kind of disease, is very low. If EV1 is low, the ratio is in fact normal. And this is very typical. What about this one? So upper airway obstruction, variable or fixed? Fixed, because we have flattening of both the expiratory and inspiratory component. What about this one? So from the volume time curve, it is a bit flattened, right? So it indicates obstruction, and there's some improvement with bronchodilators, right? And the flow volume loop, as you see. Now here I would like just to warn you that there's some air leak, but this air leak is not that significant. So as you see, there is drop in the peak expiratory flow, scalloping of the curve indicates obstruction, and the 1 second mark is right in the middle between the TLC and RV. So this indicates that there is what? Obstruction. There is some improvement with bronchodilators, yet we need to look at the numbers to see if this is significant or not. So if EV1 and FVC are both low, and the FEV1 FVC ratio is really low, so this is diagnostic of obstruction, and the severity of obstruction is probably severe because it is above 35 but less than 50. And then the change in bronchodilators, although it is 15% in FEV1, it didn't reach the 200 mils. So there's some improvement, but it's not significant. Last case, so 55-year-old male, Caucasian, a history of shortness of breath. So spot diagnosis. What do you think? Upper airway, is it intrathoracic or extrathoracic? Extrathoracic. Perfect. The inspiratory component is the one flattened. And thank you very much. And I don't know whether time will allow for questions.